Hi, and welcome to Complex Coronary Interventions from the Leeds General Infirmary. This is a case of percutaneous treatment of complex left main stem bifurcation disease. I am Dr. Abdul. I'm a consultant cardiologist at the Leeds General Infirmary. This case was performed with my colleague Dr. Murugu Veerasamy as first operator. So this is a case of an 81-year-old man who was admitted acutely with chest pain, global ST depression, and positive troponin. He went to an urgent coronary angiogram, which showed severe left main stem LAD and circumflex disease. So this was his angiogram. You can see complex calcified distal left main stem bifurcation, seen more clearly here, as well as proximal LAD diagonal bifurcation disease, as you can see here. The right coronary artery had mild distal atheroma only. This was his LV angiogram showing mild anterior hypokinesia. So discussed urgently with the surgeons, and due to the acuity of the presentation, it was decided to proceed urgently to PCI. The plan was to perform this using 7 French renal access with a strategy of minicrush bifurcation stenting. So this is a 7 French Voda left 3.5 guide catheter delivered from the right radial. We initially passed a cyan blue wire. Into the diagonal. As you can see here, nicely wide. And then went on to wire the LAD. The strategy for the LAD diagonal bifurcation was to perform provisional stenting, but to predilate the diagonal prior to deploying the LAD stent. There are pros and cons to predilation. The advantage of predilating the diagonal would be more likelihood of the vessel remaining patent. However, the downside to predilating the side branch would be potential dissection, which may make it more difficult to rewire the side branch in case it occludes. So the LAD was wired, and we then went on to wire the circumflex again with another cyan blue wire. As you can see here, there's significant proximal circumflex disease as well as further disease at the AV circumflex bifurcation. The strategy was to treat the proximal vessel only and the ostium in the bifurcation stenting. So we initially dealt with the LAD diagonal bifurcation. So we predilated the LAD with a 2.75mm NC balloon. You can see a good expansion of the balloon. And again, excellent expansion of the balloon. And again, a full expansion of the balloon at the proximal LAD left main stem. So we then proceeded to balloon angioplasty of the diagonal. But as mentioned, with a plan to treat only the provisional stent into the from the LAD. This was just a 2.5mm 15 compliant balloon. You can see here that he does have episodes of hypotension, which was treated with IV metforminal with good recovery. So we then went on to treat the mid to proximal AD across the bifurcation with a 3x23 millimeter drug-eluting stent. The key here is to avoid landing the proximal strut across the diagonal bifurcation, as you do not want to have overlapping stents across the diagonal, which will increase the likelihood of vessel closure and make it more difficult to cross into the diagonal. So we left a few struts before the diagonal, and you can see there is good expansion of the stent. So this was deployed at 14 atmospheres. We've drawn a few millimeters and we went up to 20 atmospheres here. With excellent expansion. We then use this balloon to guide us to the length of the second stent, which again looks like a 3.5, a 23 millimeter stent will suffice. Having dealt with the proximal AD bifurcation, we moved on to pre-dilating the circumflex. Again with an NC balloon. Focusing just on the proximal and osteo lesions and leaving the most distal lesion. There's good expansion with high pressure NC balloon inflation. So then proceeded to minicrush bifurcation stenting with a 3x23 millimeter drug-eluting stent from the circumflex left main, and then plan to crush this with a 3.5 by 23 millimeter stent from the LAD to osteo left main, which would be overlapping with the previously deployed stent. So here the LAD stent has been delivered. And parked in the proximal LAD. Here is the circumflex stent now being delivered. It is possible to deliver two stents easily in a 7-French guide catheter at the same time. This is not possible in 6 French guiding catheters. So the diagonal wire has now been removed. And the plan is to first deploy the circumflex stent with one or two struts in the left main stem. The LAD stent is also positioned to ensure that this can be withdrawn after stent deployment. So here the circumflex stent is deployed into the left main stem. This is deployed at 16 atmospheres. The balloon is then withdrawn and further high pressure inflation is performed to 18 atmospheres. When doing a crush bifurcation stenting procedure, it is important after deploying the first stent to take an angiogram to assess if there is any distal stent edge dissection and to deal with this at this time prior to crushing the stent in case it is not possible to open the struts and do kissing inflations. So prior to doing the crush, we take an angiogram now. This shows good result in circumflex with no distal edge dissection. So we can now remove the circumflex wire and deploy the LAD left main stem stent. So here we are. Before withdrawing the wire, we positioning the LAD left main stem stent. The LAO cranial view is usually the best view to assess the ostium of the left main stem. This looks a good position, probably needs to come back 1 or 2 millimeters, otherwise looking very good. So here the circumflex wire is now removed to avoid jailing in a crushed stent. And we then go back to the LA cranial view to ensure osteal coverage for the left main stem. This was a 3.5 millimeter stent. It's important to know the different stent platforms. This particular platform, the Zion's drug-eluting stent, the 3.5 can be expanded all the way up to 5.6, which covers most left main stem dimensions. So this is the left main stent being deployed. The balloon is then withdrawn and further high pressure balloon inflation is performed, and following this the guide is easily engaged into the stent. The key next step is to perform proximal optimization. So is a 4.5 millimeter NC balloon. It's important to do this in the caudal view to ensure that this is appropriately performed at the distal left main stem bifurcation and does not extend into the LAD. That's a 4.5mm NC balloon with appropriate proximal optimization. So we then rewired the circumflex coronary artery through the stent truss with a assembly wire. Here, Dr. Veerasamy nicely demonstrates looping the wire into the LAD to ensure that this is within the lumen of the stent prior to wiring the circumflex. If there are concerns, then a dual lumen catheter can be used on the LAD wire, which will ensure that wiring is performed inside the lumen of the stent and not through any of the stent struts in the left main. So after wiring of the circumflex, we then proceeded to perform kissing inflations. Here you can see a 3.5mm balloon NC balloon would not cross into the circumflex. So we have already placed a 3.5mm NC balloon in the LAD, which is then inflated to act as an anchor. And following anchoring, you can see nice demonstration the 3.5 NC can then be delivered into the circumflex. So we then performed high pressure inflation of the circumflex and the LAD with 3.5mm NC balloons, followed by kissing inflations at the bifurcation. So we do, at the bifurcation, we do sequential high pressure inflations followed by kissing at nominal. So here's the ostrom of the circ being post-dilated. And here is kissing balloon inflation at nominal atmosphere. The angiographic result here looks very good. We then proceeded to IVUS guided optimization. Again, angiographic result here looks good with patent diagonal vessel. We would usually perform IVUS imaging prior to guide our strategy, but in this case, due to ischemia and hypotension, it was appropriate to proceed directly to intervention. So here is the IVUS catheter, and IVUS imaging showed slightly underexpanded stent in the mid and proximal AD, which is further optimized initially with a 3.5mm NC balloon here. This is at high pressure. And the IVUS imaging also showed the proximal LAD stent to be slightly undersized, and this required further optimization with a 4mm NC balloon. So here's a 4mm NC balloon proximal to the diagonal, post dilation at 20 hemispheres. We then performed kissing balloon inflation with the 4 mm intensity balloon in the LED and a 3.5 mm intensity balloon in the circumflex. So here we are doing the kissing balloon inflations with excellent expansion of both balloons. And we did a final proximal optimization with a 5 mm intensity balloon, being careful to avoid the carina. And here is the final result. This is the AP quarter view, showing excellent results with all branches patent, excellent expansion of stent. And again, this is finally the AP cranial view, again showing excellent result with patent diagonal vessel. Thank you for joining us for this case presentation.